Thank you, Chairperson, sir. Ladies and gentlemen, very good afternoon to all of you. Over the next 15 minutes, I'm going to talk to you about the evidence-based management in the field of endocrine therapy in non-metastatic breast cancer. Okay. My disclosures, nothing to disclose. The agenda for today will be, most of the time I will be talking about adjuvant hormonal therapy and some part about neoadjuvant hormonal therapy. Now my talk will be divided into basic questions: why to give adjuvant hormonal therapy, whom to give, when to give, what not to give, how long to give, and what side effects to look for and manage. Let's see them one by one. So the basic question, why to give? The EBCTC meta-analysis of 2011 and the NCCN guidelines also reinforce the fact that ER-positive breast cancer in these, adjuvant tamoxifen decreases the annual odds of recurrence by 39% and the annual odds of death by 31%, irrespective of the use of chemotherapy, patient's age, irrespective of menopausal status or axillary lymph node status. So, adjuvant hormonal therapy is the way to go. Now, whom to give? The ESMO guidelines, there is level 1 evidence, they recommend endocrine therapy is indicated in all patients who have a detectable ER expression, which is defined as more than equal to 1% of invasive cancer cells. At least 1% positive, they should be offered hormonal therapy, irrespective of the use of chemotherapy or targeted agents. Now, when to give? Ideally, the chemotherapy should be given first, followed by adjuvant hormonal therapy. We can combine hormonal therapy with targeted agents as well as the radiation therapy. This is what is endorsed by the ESMO guidelines as well as the NCCN guidelines. In general, chemotherapy should not be used concomitantly with endocrine therapy. In patients who require both, chemotherapy should be given first, followed subsequently by endocrine therapy. Trastuzumab may be routinely combined. RT may be routinely combined during endocrine therapy. Now the basic question, what to give? Generally, we have three things in our armamentarium. First is the drug, the selective estrogen receptor modulator, which is tamoxifen. Second is the aromatase inhibitor, anastrozole, letrozole, which block the peripheral conversion of androgens to estrogen. And the third agents are ovarian suppression or ablation, which can be done by two methods. Temporarily, it can be done by ovarian suppression with GnRH agonists, and permanently, it can be done by oophorectomy or radiation ablation of the ovaries. Now, the approach depends on the menopausal status of the woman. In cases of premenopausal women, we either give tamoxifen, or the other option is to suppress the ovaries and give aromatase inhibitors. But in the case of postmenopausal women, our choice is aromatase inhibitors. Tamoxifen can also be given, but aromatase inhibitors are better in terms of disease-free survival as compared to tamoxifen. Now, this decision or algorithm is very well defined in the NCCN guidelines. These are the two circles, green circles, which clearly state the menopausal stage of the woman. For premenopausal women at diagnosis, the category 1 recommendation is tamoxifen for 5 years. Then at 5 years, you check whether the patient is postmenopausal or premenopausal. If premenopausal, continue tamoxifen for 10 years. And in case of postmenopausal, you can shift to aromatase inhibitors for another 5 years. The another category 1 evidence is as AI plus ovarian suppression. Now, for postmenopausal women, we can give aromatase inhibitors for 5 years, or aromatase inhibitors for 2 to 3 years, followed by tamoxifen, or tamoxifen followed by AI. All these three are supported by the EBCTC meta-analysis. And in patients, in postmenopausal women who cannot tolerate aromatase inhibitors for any reason, they can be given tamoxifen. Now, we see that the core message lies in the definition of menopause. We have to be doubly, triply sure that the patient is actually menopausal, postmenopausal, before giving her AIs. And for this, these are the recommended definitions as proposed by the NCCN. Either the patient has undergone bilateral oophorectomy, then she is a postmenopausal. More than 60 years postmenopausal, although the age of menopause is around 45 to 50 years, but to be doubly sure, they have taken it as 60 years. Or who are less than 60 years, if amenorrhea is there for 1 year and the patient is not taking any chemo or tamoxifen, then she qualifies to be a postmenopausal. And if less than 60 years and on ovarian function suppression, we need to check her FSH and estradiol levels, E2 levels. They should be in the postmenopausal range to qualify as a postmenopausal lady. And if the patient is taking tamoxifen, Then also we have to check the E2 and FSH levels to qualify for a postmenopausal range. What about ovarian function suppression now? Now, many experts use ovarian suppression plus exemestane rather than tamoxifen as a single agent therapy. And this is based on two trials, SOFT and TEXT. And whom do they prescribe? They prescribe it for hormone receptor positive high-risk patients. And how do they define this high risk? Less than 35 years, patients in whom the disease was so high risk as to qualify for a chemotherapy, they also qualify for this ovarian suppression for plus exemestane. That is large tumor size, high tumor grade, LVI, etc. Now, what is the basis for this? In 2014, we had two publications in NEJM about the SOFT and the TEXT trial. Basically, in the SOFT trial, the patients after chemotherapy were randomized into 3 arms, tamoxifen 5 years or ovarian function suppression by gonadotropin-releasing hormones plus tamoxifen for 5 years, breast cancer-free interval and disease recurrence-free interval compared to tamoxifen plus OFS, and making it a new treatment option. But there was no difference in OS. But what is our policy at IRCH? What do we follow? We routinely do not at present offer ovarian function suppression with GnRH agonist or by ablation and add exemestane as per this trial. And why do we not do this? Because the data on overall survival is not mature. Not all clinical situations were adequately represented in these trials. And the ABCSG 12 trial was a similar trial done in Austria, which had exactly opposite results. And the ESMO guidelines also do not approve of this strategy, that is ovarian function suppression plus exemestane. So our current policy at IRCH is not to give ovarian function suppression plus exemestane. We are waiting for the further updated results of the trials. Now, the next question is how long to give. 5 years of tamoxifen or 5 years of aromatase inhibitors is the dictum. But people have tried to go beyond this to show advantages. 10 years of tamoxifen has been studied by 2 trials, ATLAS trial and the ATOM trial. Another strategy of 5 years tamoxifen, then 5 years aromatase inhibitors has been studied by the Canadian trial MA17. And the 10 years aromatase inhibitors study was done by the MA17 trial recently last year in ASCO. Now, in the ATLAS trial, after the patient had finished 5 years of tamoxifen, they were randomized into 2 arms, further tamoxifen for 5 years or placebo. There were significant patients from our center too in this study. This was a very large study. And if you see the recurrence rate at 15 years, that is 10 years from study entry, there was a significant difference in terms of recurrence rate of breast cancer. In terms of breast cancer mortality, it was also significantly different, 12% versus 15%. But if you see the side effects, there were little higher risk of endometrial cancer and pulmonary embolism. But the experts mentioned that even though the tamoxifen can cause pulmonary embolism or endometrial cancer, the gain is 10 times more than the hazard in terms of life or death. Just to have an idea of how much benefit this 10 years of tamoxifen is giving, this is the result of ABCTC meta-analysis, 5 years tamoxifen versus placebo. And this is the hazard ratio. This is the hazard ratio for ATLAS trial, that is 10 years versus 5 years. If we multiply these hazard ratios, this is 0.94 versus 0.75, we get this hazard ratio, product estimated effect of 10 years versus placebo. And we can see there is 50% reduction in breast cancer mortality at 10 years if we give 10 years tamoxifen versus nothing. So with these results, for women with ER-positive breast cancer, continuation of tamoxifen for 10 years instead of stopping at just 5 results in further reduction on recurrence and mortality, especially after year number 10. Similar results were reciprocated in the ATOM trial, which was published just as an abstract in 2013 JCO. Then the Canadian people, they studied in the MH17 trial. It was published in 2003 and then later updated in 2012. Here, 5,000 postmenopausal women, after they completed 5 years of tamoxifen, were randomized to letrozole 5 years or placebo. This letrozole arm fared better. They had an improvement in DFS as well as in overall survival. Now, last year in ASCO 2016, Peter Goss presented his study, and it was later published in Lancet 2016, the MA17R study. In this 1,900 postmenopausal women who had completed around 4.5 to 6 years of AI, aromatase inhibitors, already, they were given 5 years of extra letrozole versus nothing. These were the patients who had tolerated this drug well. Not all patients were given, only those who had tolerated it well, they were further randomized. And then they showed that there was a very significant difference in the disease-free survival as well as contralateral breast cancer recurrence. But there were more bone-related events, bone pain, new fractures, and new osteoporosis. However, we were very fascinated with this study, that is, we could have 10 years of anastrozole. But later that year, in last year, 2016, San Antonio, NSABP 42 study, data trial, and IDEAL all were presented in abstract forms, and their results were quite contradictory to this study. So the consensus is there is divided results, and we need to discuss all these along with the side effects with the patients for additional 5 years of anastrozole. So our policy in IRCS today is we give premenopausal women 20 milligram of tamoxifen for 10 years if they do not have any toxicities. Another option is to give 5-year tamoxifen, check their status, and if they are postmenopausal, go for AI for 5 years. And in postmenopausal women to begin with, we gave anastrozole 1 milligram daily for 5 years. Now the future lies in the clinical plus genomic data risk assessment. And probably we will take a decision at 5 years of tamoxifen based on the clinical and genomic data gathered at the baseline. Now we need to know the side effect profile of tamoxifen. From tamoxifen, we have hot flashes, vaginal discharge, the sexual dysfunction, menstrual irregularities. There is a slight risk of uterine cancer and predisposition to deep vein thrombosis. So an annual gynecological checkup is a must if the uterus is present in that woman. And we should not use the SSRIs like paroxetine and fluoxetine, which have action on the CYP2D6, the metabolizing enzyme. In aromatase inhibitors, we have a significant side effect of musculoskeletal symptoms, AIMS we call it, new osteoporosis, new fractures, cardiovascular diseases, and hypercholesterolemia. So a DEXA scan for bone density needs to be done at baseline and repeated regularly. Denosumab 60 milligram every 6 months is also recommended for anastrozole-induced bone loss in these patients. Now some special situations. What about pregnancy? Women of childbearing potential, these are the women of childbearing potential, if they should be advised that they need to have effective contraception while they are on tamoxifen. And following the completion of tamoxifen, they need to at least 2 months period of washout period so that the drug gets out of their body, then only they should try for conception. What if the patient gets pregnant while on tamoxifen, because tamoxifen can induce ovulation? So tamoxifen should be discontinued because its use during pregnancy is associated with a high risk of high frequency of congenital anomalies, and the child may need to be aborted. Now, some words about neoadjuvant hormonal therapy. It is done for only luminal A, ER positive patients. We prefer aromatase inhibitors. 4 to 6 months we give, and if there is stable disease or partial response, we go for surgery. If there is progression at any point, we go for surgery. All patients who receive neoadjuvant hormonal must be followed by adjuvant hormonal. Okay. And so finally, the take-home message is as adjuvant ET is vital and indispensable component of care. We need to define the menopause of the patient according to criteria. Premenopausal tamoxifen 10 years and postmenopausal aromatase inhibitors for 5 years. We have to manage the side effects optimally and watch out for ASCO 2017 next month. We can have a change in our guidelines. Thank you very much.